We will talk here about two of the other autosomal trisomies that often carry to term. You'll be asked about this on the test. Certainly these they're not as common as Down syndrome, and these children, when they're born, they typically don't live past 1 year of life. But you will be asked about the features that when they occur in constellation, especially if there is abnormal prenatal labs. You'll be asked what the most likely diagnosis is, and so therefore you're going to want to know the features that are associated with these trisomies. Another way that you'll be asked to diagnose this or to select the most likely diagnosis on the test is in the form of the quad screen. So if you remember back to Down syndrome, where just in case you forgot, the quad screen is getting your alpha-fetoprotein, your HCG, estriol, and inhibin A in the second trimester. And if you remember back to Down syndrome, the HCG and inhibin A are high, and that's very characteristic of Down syndrome. Prenatally, with Patau syndrome and Edwards syndrome, you also have very characteristic quad screen results. Now, they're not perfect for diagnosis, but for the test, you'll want to know what those quad screen patterns are. So Patau syndrome was named after Dr. Klaus Patau, who was a German-born American geneticist, and this was really characterized in the 1960s when we got a lot more information on this. So this is trisomy of chromosome 13, and typically it is due to non-disjunction, and that's going to be the most common way that you see this come up because the number one predisposing factor by far is increasing maternal age. And what happens to a woman as she gets older, she's exposed to just the damaging factors in the environment, and her eggs ultimately are damaged over time just with normal exposure, and the spindle fibers can't properly segregate the chromosomes. And so you wind up with non-disjunction. You wind up with 2 copies of a chromosome in one gamete and 0 in the other gamete. And so that's going to lead to a trisomy or a monosomy. With trisomy of chromosome 13, we get Patau syndrome. Now, you can also get Patau syndrome, just like Down syndrome and Edwards syndrome, through a translocation, in which case you would have part of chromosome 13 on part of another chromosome, and then in that case you can inherit three copies of chromosome 13, or at least a partial third copy. And then in these cases, the Patau syndrome is actually going to be heritable. So you have a couple will have a 1 in 4 chance of having a child with Patau syndrome, and that goes for Down syndrome and Edwards syndrome too. And this is the big reason why we need to make sure that parents who give birth to a child with Down syndrome or Edwards or Patau's, that they get genetic counseling. So we make sure, especially if they're younger parents, we make sure that this is not a Robertsonian translocation, because if it is, then they're going to need to be genetically counseled on that. The excess chromosomal material from chromosome 13 is going to result in these defects, and they characteristically affect the midline, the middle face, the forebrain, as well as other defects. And Patau syndrome is almost always incompatible with life. Probably the few exceptions that there are out there are like mosaicism, but I haven't really read of any Patau's patients surviving very long. So like Down syndrome and Edwards syndrome, like I mentioned, this is associated with increasing maternal age, and it occurs in approximately 1 in 16,000 newborns. So you can see the pictures here, this cleft lip and palate. You also see here a cyclopia, and these are midline defects. So what do we see? Well, the ones I put in red here are, in my opinion, what come up most commonly in test vignettes. But you can see the prevalence it varies. So as far as the face and the head, scalp defects are pretty common. About 3 in 4 babies with Patau syndrome will have cutis aplasia, And that is just an absence of the skin. And of course, this can happen in other conditions as well. It's not pathognomonic, nor is it a sine qua non, but it is something that's very common. And I've seen this come up on test questions where they tell you that there's this cutis aplasia that's present, and usually it's on the top of the head. Microphthalmia, hypertelorism, cleft lip and palate. You kind of already saw the picture of that. Microcephaly with a sloping forehead, short neck. Holoprosencephaly, this is a big one here. Now, normally you're not going to see this when you look at the newborn because this is something that you would generally have to get a CT to see. But this is definitely a feature, and this just underscores the midline defect. Low set ears is a pretty common feature in most genetic syndromes. Or many genetic syndromes. You can also see significant Clinodactyly. Polydactyly can also be present. Hypoplastic nails is another frequent feature, but again, this is not a really specific feature. And then capillary hemangiomas are present in the majority of patients as well. Now, in other systems, and both Patau's and Edwards syndrome, similar to Down syndrome, it affects a lot of different organ systems. Almost all Patau's babies are going to have congenital heart defects. You might also see things like missing or thin ribs. There may be renal anomalies. You can see some things in the special sensory systems like cataracts and colobomas, which coloboma, remember, is just that keyhole pupil. And then there's typically deafness. And if these babies live a little longer, there's invariably going to be developmental delay and growth retardation. So this is a cartoon of what this cartoonist believes as a characteristic features of Patau syndrome, and these are some of the things that you'll see. So hypotelorism, this broad flat nose, and then the cleft lip and palate. And then they also are illustrating here the polydactyly. And usually this will come off the pinky, but you can see this elsewhere too. So this is cutis aplasia. So what you see here is the skin is really thin, but for the most part it's really defaced. Now this is not this particular baby is not a baby with Patau syndrome, but this is what cutis aplasia looks like. So this actually is a baby with Patau syndrome, and this is a postmortem picture, obviously. But you can see here a few things. You can see the cutis aplasia that's most prominently on the top of the head, like I mentioned. You can also see the low set ears. You can see the cleft lip and palate, and then you can also see here a little appendage, and that's coming off of the pinky, and that's polydactyly. So here's a bigger picture of that cleft lip and palate. So this is cyclopia. This is reflecting the midline defect. This is a CT, and this is holoprosencephaly, and this is seen in a lot of midline defects. There's lots of different syndromes that can cause holoprosencephaly, but what you see here is that you don't have, you basically have one big brain. You don't have separation of the sides. So note that right here. Okay. And then here's this is a picture of the actual brain. This is Clinodactyly, so this is something you'll see in Down syndrome as well as in Edwards syndrome. But what all Clinodactyly is it's a bending of the fingers, where the fingers bend to the sides. This is a polydactyly here, so you just note this little appendage here coming up of the pinky. And you can also see it on the toes as well. And it also happens to be on these fifth digits. For diagnosis, formally to diagnose Patau syndrome, you would need a chromosomal analysis. That would be the most accurate test. But in many cases, this diagnosis is expected prenatally based on obstetric screening that we do on all women. So on sonography, typically you'll see a baby that's small for gestational age, which is reflecting intrauterine growth retardation. There can also be, I guess I didn't really finish this, you can also see an increased nuchal translucency. and that's similar to what you see in Down syndrome as well. In the second trimester, when you get the quad screen or the triple marker screen, what you're going to get is an elevated alpha-fetoprotein level. So remember the mnemonic AF Patau, and that's going to be elevated. The rest of them will be typically within normal range. If you get a quad screen or a triple marker screen that comes back suspicious for any trisomy, then what you're going to want to do is get a chorionic villus sampling. And this is done right around the same time that the triple marker screen is done, which is about the beginning of the second trimester, so around 12, 13 weeks of gestation. And this is done for mothers with suspicious results on sono or marker screen. You can also do it on women. It can be offered to women who are advanced age, who have increased likelihood of delivering a baby that has one of these syndromes. Also should be offered to women who have a past history of a baby with trisomy. And then amniocentesis is really the gold standard as far as OB screening, and that can be performed after 15 weeks gestation, but it doesn't need to be performed. These two tests, your marker screen and chorionic villus sampling, together those have a pretty good predictive value. But you can do all three. You could do the triple marker screen, amniocentesis. It's really up to the call for the most part of the obstetrician. So what do we see as far as the quad screen or the triple marker screen? You're going to see a high AFP. The rest of the values should be normal. For management, if it's suspected prenatally, the mother should deliver the baby at a specialized center, both for care of mother and for baby. But there should certainly be some counseling so that the mother knows exactly what to expect. If the diagnosis is suspected only after birth, so perhaps a woman who did not get good prenatal care and did not get her screenings done, then if you suspect the diagnosis only after birth, then obtain immediate cytogenetic profile. Obviously, we want to, that's the best way to diagnose it after the child is born. But if you already suspect based on your prenatal labs, and then you have this child now in front of you who looks like they have a trisomy, you don't need to get a cytogenetic profile right away. You'll want to typically refer this baby to neonatology because they're going to need very specialized care, but at the very least consult them. General management will be provided as needed, but you'll need to discuss the severity of the condition with the parents if you haven't already, because these children typically die within weeks after birth, if that. So after that, certainly parents should be advised to obtain genetic counseling if they're planning future pregnancies, and that's mostly because we're concerned about the translocation. Now, a translocation is not going to affect, you can be a carrier of a translocation. I actually am a carrier of a translocation myself, as a matter of fact. And you can be a carrier of a translocation and be perfectly fine, and in many cases you can actually have babies, but what the implication of that is that you're going to have a child with, you're going to have a higher likelihood of miscarriages and these genetic conditions. So if you have a set of parents that give birth to a baby with Downs or Edwards or Pataus, you want to make sure that they get genetic counseling, and so that they can get cytogenetic analysis to make sure that you detect that translocation if it's present. And this is especially advisable in younger parents, because remember, or particularly if the mother is younger, because remember that this is associated with advanced maternal age. So if this is a mother who's 25, 26 years old, and she gives birth to a baby with Patau syndrome or Down syndrome, then that might be a translocation, because the odds of giving birth to a baby with one of these trisomies, if you're younger, is a lot lower than it is if you're older. All right, so on to Edwards syndrome. So Edwards syndrome is a trisomy of chromosome 18. So I don't know if you know the mnemonic for Patau, Edwards, and Downs, so PED, peds like pediatrics, and it's 13, 18, and 21. So if you're watching this and you're familiar with the United States, it's at age 13 you can get into a PG-13 movie. It's at age 18 when you can vote and you become an adult, and it's at age 21 when you can drink. So that's your Patau, Edwards, and Downs, 13, 18, 21. So Edwards is a trisomy of chromosome 18. It was named after John Hilton Edwards, who was a British geneticist, right around the same time when Patau was discovering Patau Syndrome. And this is also typically due to a non-disjunction, but it can also, similar to Patau and Downs, be due to a translocation. Edwards syndrome is almost always incompatible with life. There are a few cases of actually teenagers who have and young adults who have Edwards syndrome, but almost always this is going to be incompatible with life. It is seen somewhat more commonly in female neonates, and it's also associated with increasing maternal age. And this actually is the second most common autosomal trisomy that carries to term, second only to Down syndrome, and it's 1 in 6,000 live births. So this is about 2.5 times more common than Patau syndrome, but certainly much less common, about tenfold or 8-fold less common than Down syndrome. And these characteristic features that you see in Edwards syndrome is this clenched fist. You see this clenched fist all the time in Edwards syndrome. This is almost, it would be an unusual case if you had an Edwards baby that didn't have this clenched fist. It's so characteristic. And then also these rocker bottom feet. And rocker bottom feet can happen in other syndromes, but this is also another thing that the USMLE loves to throw at you, so the rocker bottom feet with Edwards syndrome. So on the head, you're going to see tight palpebral fissures, a narrow nose, and hypoplastic alae. The alae are just the flares of your nose, but when you're looking at a baby, they tend to have a small nose to begin with, so this isn't going to be very pronounced. But if you look at an older child with Edwards syndrome, if they do indeed live that long, you will note the hypoplastic and narrow nose. Microcephaly is very common and very pronounced in Edwards syndrome. Hypertelorism, micrognathia, narrow bifrontal diameter, that's just reflecting the microcephaly, and then they also have low-set malformed ears. The extremities, you're going to see rocker bottom feet, clenched hand. They also can have Clinodactyly and hypoplastic nails. Other features that they can have, they tend to have hypertonia. You'll see these pictures of these babies. Most of them you can see some of these manifestations of hypertonia. Omphalosia is another thing that tends to happen in Edwards syndrome. I think about half of the babies will have an omphalosia. And then they also have some of these other non-specific features that you see in other trisomies, like congenital heart defects, developmental delays, and so forth. And only about 5% of these babies will live past 1 year of age. So again, here's another representation of this syndrome, Edwards syndrome. So hypertelorism, which is just increased space between the eyes, upturned nose, small jaw, that's your micrognathia, low set ears, and then the rocker bottom feet and this clenched fist. So here's the rocker bottom feet, and this, oh, I should have put in a picture of a rocking chair. Okay, so if you've seen a rocking chair, you should know how this gets its name. So just note the heels here on the back. They extend out a lot more, like a rocking chair. So a rocking chair, you know how it's shaped. It looks just like this. Right, so these heels are pointed backwards too far. There's the tight palpebral fissures, so not a lot of space in between the sides of the eyes. Okay, so here's that clenched fist, but you also see slightly hypoplastic alae. This is an older child, so it's a little bit easier to see the narrow nose. But there's that clenched fist. And you're going to see this again. There's two clenched fists. You can also see the hypertonia here. This baby is sort of in an abnormal position. And then the microcephaly on the back of the head, you really see it here. So there's that clenched hand again. Here again, you see the clenched hand. It looks like there's some abnormalities of the digits. There's hypertonia here. and it looks like this baby also has microcephaly as well. So here's a long-term survivor. This is extremely rare, but obviously these children are going to have developmental deficits, mental retardation, but you can see here some of these features of Edwards syndrome. So what I particularly wanted to point out here is the hypoplastic alae. So note this very narrow nose, and it's not so much the bridge of the nose, it's not so much the nose bone itself, but it's the cartilaginous sides of the nose that are hypoplastic. Right, so right on the sides of the nose here. All right, so when you do the quad screen with Edwards syndrome, the mnemonic is HE are low, and so that's going to be the HCG and the estriol are both very low. So again here, formal testing is going to require chromosomal analysis, but in many cases the diagnosis is made prenatally. The obstetric screening on sonography, it may demonstrate that abnormal positioning of the fetal fingers, that sort of clenched fist. You can see that even in utero. You will also see in almost all cases an increased nuchal translucency, similar to what you see in Down syndrome. You can see the abnormally shaped head reflecting the microcephaly, intrauterine growth retardation, and in some cases some phalloceal. At the second trimester, you're going to get the quad or triple marker screen as in all pregnant women, and again you're going to see the HCG and estriol are going to be low, particularly the HCG. It's going to be very, very low. Chorionic villus sampling, of course, is going to be done for women with these abnormal marker screens, and again, the same indications as usual for CVS. And amniocentesis can be performed if usually what's going to happen when you're going to do the amniocentesis is if the mother had the abnormal triple marker screen, but now you're past 13 weeks of gestation, you can do amniocentesis. And so that can be done after 15 weeks of gestation. Management is pretty similar here to what we do with Patau syndrome. Pretty much we're dealing with, in almost all cases, a baby that's not really going to live very long. And so it really is up to the neonatologist and the parents as to how far they're going to go as far as treating the baby. Preterm management, of course, if it's suspected prenatally, you want this mother to be delivering at a specialized center where this can be anticipated. The diagnosis, if it's suspected only after birth, again, like Patau syndrome, then you're going to obtain immediate cytogenetic profile because that's really the only way to diagnose it after birth. Neonatology, you'll want them on top of this because this is obviously a very complicated infant. And then general management is needed in discussing the severity of the condition with the parents. Of course, the parents should be, again, advised to obtain genetic counseling, especially if they're much younger parents, much younger mother, to plan for future pregnancies and to get cytogenetic testing to make sure that, to see if they're carrying a translocation or not.